We will start a series of presentations, about 3 presentations to cover the urogynecology module. Urogynecology is a very important subspecialty in obstetrics and gynecology because it deals mainly with the quality of life. Most of women, because of childbirth and age, menopause, some surgeries are exposed to urogynecology complications like stress incontinence, like pelvic organ prolapse, like overactive bladder. That's why really by knowing these topics and understanding the proper management, you are improving the quality of life for your patients. There are mainly 4 topics in the urogynecology module, which are pelvic organ prolapse, and part of it is the post-hysterectomy vaginal port prolapse. We have urinary incontinence with its different types, and painful bladder syndrome. So today we will start with the most common topic, I believe, which is the post-hysterectomy vaginal port prolapse. And it's common because a lot of women have hysterectomy at some point in their life, either because of fibroid uterus, because of menorrhagia, as part of dysfunctional uterine bleeding, endometrial hyperplasia, etc., etc. And going for a total hysterectomy will increase the risk of port prolapse in the future. This doesn't mean that subtotal hysterectomy prevents this risk. Indeed, the studies found that both total and subtotal hysterectomy have an equal risk for post-hysterectomy vaginal port prolapse. We will go through the definition of post-hysterectomy vaginal port prolapse. We'll go to how to diagnose that, how you can prevent it. If the patient presents to you in clinic complaining of a prolapse, how you will assess her. We'll go also through pelvic organ prolapse quantification system and different management options you can give to the patient. So what is the definition of post-hysterectomy vaginal port prolapse? It is a descent of the vaginal cuff scar below a point that is 2 cm less than total vaginal length above the plane of the hymen. Definition will be quite clear when you saw how we make the pelvic organ prolapse quantification system. Because we have fixed points like total vaginal length. If this total vaginal length, for example, is 8 cm, and total vaginal length should be measured when the patient is in resting position, not in valsalva, where return the vault or the cervix if present before hysterectomy to the normal site, and measures total vaginal length. So if it's 8 cm, for example, then we find the vault descending to a point which is about 5 cm from the hymen. This means that there is a prolapse. For assessment of a patient with post-hysterectomy prolapse, it is like any assessment in obs and gynae. There are main 3 items, which are history, examination, and investigation. By history here we mean first, what is the patient complaint? So is she coming because of pain? Is she coming because of pressure? Is she coming because of ulcers? Is she coming because of bladder and bowel problems like voiding difficulty? She has to push the prolapse up in order to be able to pass urine, or that she has frequency, that she has urgency, this affecting her bowel, that she has constipation, that she has difficulty in defecation, how it's affecting her quality of life, is she sexually active or not, because this will affect the way we are going to treat her. However, there are other points in history as well, so we need to take a full history. There's not just the patient complaint. We need to take the past history. Why she had hysterectomy? Was it because of cancer? Was it because of menorrhagia? Was it because of fibroid? Her medical history. Does she have any medical problem which predisposed to recurrent prolapse? Because this will affect your way of counseling. For example, does she have asthma or COPD, chronic cough, chronic constipation, irritable bowel syndrome, neurological disorder like multiple sclerosis, all of these will affect your way of managing. And surgical history as well. Does she have previous repair, for example? Does this post-prolapse was present and she has previous repair, or does she have a prophylactic surgery at time of hysterectomy, like sacro-spinous fixation or colpopexy? You need to ask about social history, like smoking. And if she is smoking, if she's a smoker, you need to counsel her about the importance of quitting or even reducing of smoking, because this will affect the incidence of prolapse and its recurrence in the future. Then you go for examination, which we will discuss in detail about the pelvic organ prolapse quantification system. But you need as well to look at any scarring. You need to look at previous signs of previous surgery, cyst, urethral diverticulum, any abdominal masses, patient with high body mass index. You need to count them about reducing weight. For investigations, you need urine depth test to exclude urinary tract infection, but you don't need urodynamic as a part of initial investigation for prolapse. That's why I wrote here, urodynamic is not recommended as an initial investigation for patients with post-hysterectomy vaginal aortic prolapse. If we discuss the pelvic organ prolapse quantification system, and this is the main tool which we use in urogynecology for assessing the degree of prolapse, and its main value is to reach a standard approach and assessment, and accordingly the management of patients with pelvic organ prolapse. As you can see in the diagram, we have 9 points, which we will turn these points into number, and we will put it in the grid as will shown in the next slide. The first point is AA, and this is A anterior, which is 3 cm proximal to the hymen. And the second point is PA, which is point B in the anterior vaginal wall. And actually it is not a fixed point, indeed it's a distance, which means the most bulging point of the prolapse. And it can be anywhere between -3, which is the position of point A, and the total vaginal length. Point C, which is the cervix, or if the patient had a hysterectomy, it will be the vaginal cuff scar. Point D is the Douglas pouch, and its main value is to show an enterocele. And remember that in a patient who had a total hysterectomy, point D is absent. Then on the posterior vaginal wall, we have again 2 points, A and B. So the point A is again 3 cm proximal to the hymen, and the point B, again, it's a distance which can be anywhere between -3 cm and the total vaginal length. Then we have other 3 landmarks, which are genital hiatus, which is distance between the medial-urethral sulcus and the posterior fourchette, and perineal body, which is distance between the posterior fourchette and the anus, and then the total vaginal length, which should be measured in the resting position. And here is the 9-point grid, which we transfer the points after we measure them and put the measurements here. And based on these measurements, we start to classify the degree of prolapse or the stage of prolapse. And we have 4 stages of prolapse. Stage 0, where there is no prolapse and all the points are at their normal position. Stage 1, which is the most bulging point, is less than a centimeter protruding. Stage 2, which is the most protruding point, is anywhere between -1 and +1. So in simple term, it can be, if the most bulging point is either a centimeter above the plane of the hymen or below the plane of the hymen, proximal or distal to the patient. Stage 3, where the most bulging point is protruding more than a centimeter outside the hymen, but less than 2 centimeters of the total vaginal length. And stage 4, where there's complete protrusion, in which it is the total vaginal length. We classify each wall alone. For example, if point AA is -2, which means that point AA is 2 centimeters proximal to the plane of the hymen, but point PA is +1, which means that point PA is 1 centimeter distal to the plane of the hymen. In this case, this means that we have a stage 2 anterior wall prolapse or cystocele. If point AB in the posterior wall is at +1, which is 1 centimeter distal to the hymen, while point BB in the posterior wall is at +3, which is 3 centimeter distal to the hymen, this means that we have a stage 2 posterior wall prolapse. So what I differentiate between stage 3 and stage 4, if total vaginal length, for example, is 8 centimeter, as we know the normal between 8 to 10 centimeter, and we find that the most bulging point is about 6 centimeter outside, or make it easier, 5 centimeter outside the hymen. So this means that it is still 3 centimeter to go to be total vaginal length. So if we make total vaginal length, which is 8 minus 2, it's 6 centimeter, and the most bulging point is only 5 centimeter, so it's stage 3. But if the most bulging point is 7 centimeter outside the hymen, so it is more than 6, which is the 8 minus 2, so it will be stage 4. I hope it's easy, the classification. For management, we have to offer the patients all different types of management, starting from do nothing, which is just observe. Because some women may come to you worried about the sensation, about the pressure, or about the pain, but they are coping, they don't really need any intervention. So you counsel them. The first line is do nothing. Physiotherapy should be done under direct supervision from physiotherapist. Usually it's about 8 contractions 3 times daily. And physiotherapy, you have to give it for 3 months at least. And then we can decide whether it's successful or not. Physiotherapy is very effective in stage 1 and 2 prolapse, less effective in stage 3 and 4 prolapse. Typical estrogen in postmenopause, especially if they have vaginal atrophy, it can help again with strengthening the muscle, and it can add benefit to the physiotherapy, but we can't offer it as a sole treatment for a prolapse. And then we'll go to the pessaries. Pessaries are one of the line of conservative management. We have different types of pessaries, but all of them can be classified under 2 categories, which is either support or space occupying. As you can see here in the slide, we have different types like Smith, Hodge with support, ring pessaries, cube, rigid Gellhorn, shelf pessaries, and we really choose that type which fit the patient. For main, depending on first the type of prolapse, second whether the vaginal wall are strong or not, third is the patient sexually active or not. Patient, before trying pessary, to understand it's a trial and error, and we can try different types first before we reach the type which is suitable for her. Most pessaries need to be changed every 4 to 6 months to avoid ulceration, infection, calcification. So really in frail patients with bad memories, with they cannot remember, it needs to have a card or some sort of reminders that these patients need to change their pessary at the proper time to avoid complication. As we said before, these pessaries, also they are different types and sizes, but they fit into two main categories, either support. And support, it depends on the vaginal muscles. So if the patient has a good pelvic floor muscles, so they can retain the pessary in situ. In this way, the support pessary will be the beneficial one, and the most common type is the ring pessary. And the ring pessary can be changed between 4 and 6 months. And during COVID now, we can extend up to another 3 months, and then review, and it can be another 3 months. So which means that ring pessary can stay actually for a year. However, we don't recommend that because of the increased risk of ulcerations, infection, calcification, rarely fistula. But the space occupying pessaries, the other type, it depends on creation of a negative pressure and suction power. So they act mainly when there is weak vaginal muscles. We use them mainly when there is a weak pelvic floor muscles. So these muscles cannot support the retention of the pessary inside, so we can't use the first type, which is support, so we use the space occupying, and the most common types of that is the Gellhorn pessary. For Gellhorn, you need to change every 4 months. For surgical management, we can do either through vaginal approach or abdominal approach, and can be laparoscopic as well now. And really it depends again on the patient criteria and her wishes and her sexual activity and whether she had previous surgery or not. The types of surgery depend again on the type of prolapse. For example, we have anterior repair if patient has cystocele, posterior repair if has rectocele, sacro-spinous fixation in case of aortic prolapse, vaginal hysterectomy in case of uterine prolapse and the patient doesn't want to preserve her uterus, and fascial direct site-specific repair. It was an era where they proved its benefit, that these prolapse happened due to a tear in the fascia, and accordingly, if we dissect and find this defect and repair it separately, it will help to strengthen the fascia and accordingly repair of the prolapse. However, nowadays it proved it's not successful. And for abdominal approach, we have sacro-colpopexy, which involve putting a mesh, attaching it to the anterior medullary line in front of the sacrum, which can be done also through a laparoscopic approach. As we can see in this slide, the abdominal sacro-colpopexy, which entails the use of a mesh, which is usually a Y-shaped mesh. Y-shaped mesh, there are two limbs of the Y and the tail of the Y. So the two limbs of the Y are attached mainly to the anterior and posterior vaginal wall, while the tail of the Y is attached to the anterior longitudinal ligament in front of the sacrum. This operation carries high risk of bleeding, beside being a laparotomy, which entail prolonged hospital stay, risk of infection. So how to choose the type of operation, how to decide which operation fit to the patient. First, for example, if you have an old frail woman, which actually not sexually active and has a lot of comorbidities, so you would like to offer her the shortest possible procedure if needed, which will be colpopexy. And by colpopexy we mean that it can be done through different ways. The most common one is creating a rectangle in both the anterior and the posterior vaginal wall by taking the vaginal wall out and then switching the mucosa together, creating two channels on both sides for secretions to come out. It's a very quick procedure. Sometimes it can be done under local, and it helps with patients who have prolapse and multiple comorbidities that not fit for prolonged surgery. But definitely, if patient is sexually active, fit and healthy, so this procedure will not fit the purpose, and she will need a constructive procedure or restorative procedure, which will restore the function back to anatomy. We restore the anatomy back, and accordingly we can restore the function of the vagina back, like anterior repair and posterior repair or sacro-spinous fixation. And here we have to consider whether it is short vagina or not, does she have previous surgery or not, is she going to have another laparotomy at the same time or not. For example, if the patient has short vagina, then abdominal approach will be better than the posterior approach, which by that I mean abdominal sacro-colpopexy. Or if she's going to have an abdominal hysterectomy, for example, for fibroid uterus, then we can do the abdominal sacro-colpopexy at the same time. Sacro-spinous fixation is a preventive procedure for post-hysterectomy vaginal aortic prolapse. Can be done at the time of vaginal hysterectomy if we find that the aorta is coming to the introits as time of closure. But it can lead to short vagina, and at the same time it leads to pathotic pain. Also, it increases the risk of anterior compartment prolapse because of the tension which is applied, and it mainly done through the posterior vaginal wall. But it's simple, easy, and effective procedure as well. And if the patient has a uterine prolapse, we need to know whether she wants to preserve the uterus or doesn't want to preserve the uterus. If you want to preserve the uterus, then we can do vaginal sacro-spinous hysteropexy, in which we fix the cervix of the uterus to the sacro-spinous ligament in simple term, or Manchester repair, But Manchester repair is mainly effective in case of cervical elongation and not a uterine prolapse. And these are two different categories actually. So patient has a uterine prolapse in which the uterus itself is protruding down to the hymen or even through the hymen. But cervical elongation is uterus at its place, but cervix is elongated. And this can be discovered through the difference between point C and point D and the total vaginal length. So you will find that point C, for example, is at -2 or -3, while point D is 8 centimeter, is -8, which is the total vaginal length. So which means that the cervix which is long. But on the other side, if point D and point C are both coming down, it's most likely a uterine prolapse. And then we have sacro-spinous with a mesh, which can be done either through abdominal or laparoscopic approach. But if she doesn't want to preserve the uterus, then vaginal hysterectomy will be the ideal option. With or without sacro-spinous fixation, as I said before, it depends. If at the time of closure the vault is coming down to the introitus, then sacro-spinous fixation would be helpful. This pathway shows a summary of how to choose a procedure. So first ask yourself, is this patient elderly, not able to tolerate surgery, no longer desire vaginal intercourse? If the answer is yes, then we have to go for obliterative surgery or colpopexy. If the answer is no, we have to go for reconstructive surgery or restorative surgery, where we are going to restore the function and the anatomy back to normal. Next question is the patient has a stress urinary incontinence, either symptomatic or urodynamics, or does she have an apical prolapse? If it is yes, then you have to add an anti-incontinence procedure. If it is a no, then there is no need for that. Remember, there is nothing called a prophylactic anti-incontinence procedure. Then you have to ask yourself third question, is there another pathology, a cervical pathology or a uterine pathology, uterine fibroid? Is there a requirement for a hysterectomy? Does the patient want to have pregnancy or not? Does she want to preserve her uterus or not? If the answer is yes, in this case hysterectomy can happen if case uterine prolapse. If it is no, then no hysterectomy is needed and we can go for other procedures with preservation of the uterus. Patients should understand that procedures with preservation of the uterus has a high recurrence rate. And at the same time, she has to understand that the recurrence rate in general of prolapse is about 5% without the use of mesh. Then whether to use abdominal approach or vaginal approach will depend on does she have previous surgery before, short vagina or not, and previous laparotomy or not. Sacro-spinous fixation is a very common procedure nowadays. As I said before, it's one of the preventive procedures for aortic prolapse. Other procedures like MRCOG II, in which we suture the uterosacral ligament to the top of the vagina at time of closure. High tracheal ligament suspension can be used, but it can risk ureteric injury. But because sacro-spinous fixation is common, we need to understand the complication of it. And the most common complication is bleeding. And why bleeding? Because there is multiple and varied collateral vascular supply and anastomosis in the region of sacro-spinous ligament. As you know that we put the suture about 2 centimeters medial to the ischial spine. In order to avoid all these blood vessels which are anastomosed together, like superior gluteal, inferior gluteal, internal pudendal, vertebral, middle sacral, lateral sacral, and external iliac via circumflex femoral system. And because of this multiple anastomosis, surgical ligation of internal iliac artery will not help if bleeding happens. That's why you have to be very cautious while putting your stitch to avoid injury of the blood vessels. And the most common injured vessels is the inferior gluteal artery. And if it's injured, you have to use packing or vascular clips. If your hospital have facility of arterial embolization and the bleeding is continuous, then you can make use of that. Thank you for your time listening to this presentation. If you have any questions, just put it on the YouTube channel and I will answer you in the comments. Please don't forget to like and subscribe if you would like to get more videos. Thanks.